Hi everyone, I'm Julie Fleshman, President and CEO of PanCAN. I'm excited to be with all of you today for a conversation with leading experts about the critical role that testing plays in early detection and better treatments for pancreatic cancer. Thank you for joining us during Pancreatic Cancer Awareness Month and today on World Pancreatic Cancer Day. I hope you're also joining all of the other supporters around the world wearing your purple today and spreading the word about all of the PanCAN efforts that you make possible. There will be a lot of information provided today, so please know that PanCAN's Patient Services call center is available to you via phone and email Monday through Friday from 7 a.m. to 5 p.m. Pacific Time. Through our free services, you will be connected to an expert case manager who can provide answers to your questions. I'd like to take this opportunity to thank our November awareness sponsors, Ipsen and AbbVie. Thank you also to our webinar sponsors, AstraZeneca, Ipsen, and Novocure. And finally, I'd like to thank our scientific and medical affairs industry members, AbbVie, AstraZeneca, FibroGen, Immunovia, Ipsen, Labcorp Oncology, Novartis, Novocure, Pfizer, Rafael Pharmaceuticals, Tempus, TYME, and ViewRay. We couldn't do what we do without our sponsors. And finally, a special thank you to all of our donors who have joined today to learn more about the latest advances and the research that you have funded at PanCAN. Before we get started, I want to tell you a little bit about PanCAN. Our approach to fighting pancreatic cancer is comprehensive. We will invest over $28 million this year in research that is advancing early detection strategies for pancreatic cancer and accelerating new treatment options for patients. We also advocate in Washington, D.C. to increase the federal resources that are available to pancreatic cancer researchers across the country. Our amazing patient services program is available to anyone free of charge and provides the opportunity to speak to one of our trained case managers and get comprehensive information about the disease. Finally, our community engagement program includes our incredible volunteer network. PanCAN has 58 volunteer affiliates across the country that raise awareness about PanCAN and pancreatic cancer and funds through PanCAN Purple Stride events that help fund our mission. I encourage you to visit our website at pancan.org to learn more and see how you can get involved. Today, we are going to focus on testing, both genetic and biomarker testing, and the importance of this information for patients to help them determine the best treatment and for family members to better understand their risk. PanCAN has played an extremely important role in conducting research and publishing findings that have led to genetic and biomarker testing becoming the standard of care for pancreatic cancer patients. And we won't stop there. There is much more work to be done. Joining me here today are 4 special guests that I'm excited to introduce you to. Dr. Eileen O'Reilly is an oncologist and the Director of Medical Initiatives at the David M. Rubenstein Center for Pancreatic Cancer Research at Memorial Sloan Kettering Cancer Center. She is a principal investigator for PanCAN's Precision Promise clinical trial, and she is a member of our Scientific and Medical Advisory Board. Dr. Michael Pishvaian is an oncologist and the Director of Gastrointestinal Developmental Therapeutics and Clinical Research Programs for the Johns Hopkins Kimmel Cancer Center in the Greater Washington area and Associate Professor at the School of Medicine. He's also been a leading scientific collaborator on PanCAN's Know Your Tumor Precision Medicine service. Dr. Alison Klein is a professor of oncology, pathology, and epidemiology and co-leader of the Cancer Prevention and Control Program at Johns Hopkins Medicine. Dr. Klein is also a member of PanCAN's Scientific and Medical Advisory Board. And finally, I'm so pleased to introduce Teona Ducre. Teona is a member of PanCAN's Survivor Council and is a volunteer in our Atlanta affiliate. A native of El Paso, Texas, Teona has lived in the Atlanta metro area since 2013 and has 2 children in college. She was diagnosed with stage 3 inoperable pancreatic cancer 5 years ago when she was just 41 years old. I'm so thrilled to have Teona on the panel today to talk about her experience with testing and share her incredible story. Thank you so much to all of you for being with us today. Let's jump in. Dr. O'Reilly, although we still have a long way to go to improve patient outcomes, the pancreatic cancer field has certainly come a long way. Some of the recent advances related to testing are exciting, both for pancreatic cancer patients and their families. So let's start by discussing the importance of testing for patients to determine their best treatment. Can you explain to everyone what genetic testing for inherited mutations and biomarker testing of a patient's tumor are? How are these different, and what information does this provide to patients?
So thanks very much, Julie. These are really important points, and we want to highlight this for the audience today. So let's start with the germline testing, and that's looking at inherited genes, so genes that are changed, abnormal in terms of DNA, and we can inherit abnormal genes from a family member, from our parents. And some of these genes can predispose to different types of cancer. So for example, BRCA1, BRCA2, known for their association with breast and ovary cancer in particular. But in our world, pancreas cancer and prostate cancer are important relationships of the BRCA genes. And there are other genes as well, including, for example, Lynch syndrome genes in mismatch repair. These are genes involved in DNA repair, and these can be associated with pancreas cancer. PALB2 is another gene that's associated, for example, with breast and pancreas cancer. And these can be evaluated by a blood test that's called germline testing. And if we identify one of these genes in a person with pancreas cancer, then there may be implications in terms of testing for additional family members, depending on what that specific gene is and what its pathogenicity or what its potential for trouble might be. So that's germline testing. And if I can go to the second part of your question, is what's somatic or biomarker testing in the tumor? This is looking at genes that are exclusive, not always, but usually found in the tumor itself, that are not inherited, right? Important to emphasize that these are not inherited. These can be associated with implications for treatments, and we have a number of genes that we consider what are called actionable. So they are something that has been utilized or validated for clinical decision-making in the clinic. Now, this is not as straightforward as it sounds, and it's best, I would say, ideally, that these testing are done together as an integrated test. We get greater clarity what's in the bloodline when we look at blood and tumor, and we get greater clarity at what's exclusive to the tumor when we look at tumor and blood, and do it as an integrated testing. But this is a very important development in the last couple of years, the fact that there's a routine recommendation for both germline testing and for people who are going on to receive treatment for somatic or tumor-based testing.
Great, thank you. That was a really clear answer. But as you said, this is complicated and people have lots of questions about it. So we will continue to duplicate this definition over and over again throughout this event. So Dr. O'Reilly, is it recommended that all pancreatic cancer patients get both genetic and biomarker testing?
Yes, well, starting with the germline testing, so the bloodline testing, that is now part of guidelines since approximately 2019. And part of this is a credit to work from Pancreas Cancer Action Network, the Know Your Tumor program, and many other enterprises in the US that have underpinned genetic testing. So it's in the National Comprehensive Cancer Network guidelines, and it's in the American Society of Clinical Oncology guidelines for germline testing. And that involves a panel with genes that we've touched on: BRCA1, BRCA2, the Lynch genes are 4 common ones, PALB2, a gene called ATM, and then there's a series of less common other genes that we look at. With regard to somatic testing, that came a little bit later, but that now is routine as well, again, for any individual who's a candidate for additional treatment. And I would argue that we have trials in early stage disease, so people who've undergone surgical removal of their cancer and getting preventative standard treatment. There are possible targeted options that build off that space that would warrant somatic or tumor-based testing in early stage pancreas cancer. So the field maybe isn't completely there yet in that latter point, but I would say that that is the goal, to recommend that every person who's getting treatment has both bloodline testing irrespective and tumor-based testing.
Great. And, we hear a lot about precision medicine in the news. This is something that people, talk a lot about. So how is testing related to precision medicine?
Yes, so another great question. And we have the POLO study, which is an important phase 3 trial that was conducted in pancreas cancer in individuals who have a BRCA1 or BRCA2 germline, so bloodline result. And in that setting, people who had these mutations received platinum-based therapy, and those who had control of their cancer or shrinkage of their cancer were candidates to go on to receive a targeted medication. And this class of drugs is called Parp Inhibitors, and that specific drug that was led to FDA approval as part of the POLO study was olaparib. And that's sort of provided the proof of principle that genetic testing in pancreas cancer has implications in terms of clinical care. That's one example, and that's probably the highest level of evidence that we have right now. There are less frequent somatic alterations that are identified in the tumor that are potentially actionable too. And so, for example, about 1% of people with pancreas cancer will have a mutation in the KRAS gene with 12C, that's a specific subset of the KRAS gene. And there are drugs that are in development. One has been approved for lung cancer and in development with combinations for pancreas cancer in that setting. We also know that there's a percent or two of people who have alterations in mismatch repair genes, the Lynch syndrome, but in the tumor part, the consequences are in the tumor, and that can lead to an indication for the use of immunotherapy. And that's an FDA-approved indication. And then there are a few rarer examples of what we call fusions. These are alterations in the tumor that occur in the absence of a KRAS mutation, and there may be 0.5% or so individually, and there are 6 or 7 of these that can occur in pancreas cancer, and a couple have what we call a disease agnostic indication in terms of a related drug that's approved for use in this setting. So larotrectinib and entrectinib for NTRK fusions in pancreas cancer that are found in the tumor. These are not inherited alterations. So Julie, these would be some examples of precision medicine and how we apply this in the clinic in 2021.
Great. So let's turn to talking about how genetic testing can be used by family members. Dr. O'Reilly, how is genetic testing, you've talked a little bit about it, useful to family members of a pancreatic cancer patient?
Thank you, Julie. Another really important question. So what are the implications beyond the person who has pancreas cancer? And it depends on the gene. So for example, if a person with pancreas cancer has a BRCA1 or BRCA2 genetic mutation in their bloodline, then that could be, or it is, the index person in the family that could suggest that there'd be other family members who may also carry this gene alteration. And there would be a recommendation for genetic testing to be conducted, or genetic counseling to be conducted with the family members, and any first degree and sometimes second degree relatives will be recommended testing to look for that specific gene. So there are implications for the person. We've talked about actionability in the tumor and in the bloodline. And perhaps the bigger implication maybe right now for identifying these families who carry these genetic alterations, who may be at risk not just of pancreas cancer, but of breast or ovary cancer and the Lynch syndrome and endometrial, stomach, what we call urothelial or genitourinary malignancies, colon cancer in that setting, PALB2, another gene that's in the bloodline, breast cancer. So all of these are really, really important for that particular family and require sort of follow on. And this is a kind of a key area is how we communicate that information and how people have access to testing and have access to counseling in terms of understanding whether or not they should get tested and when they should get tested and what might be the implications for screening considerations for that particular person and their family.
Yep, thank you. Yeah, it's definitely complicated and something that someone should really talk to their healthcare professional, a genetic counselor, about to better understand it. So, overall, Dr. O'Reilly, I mean, this is a really important topic. Why is this topic of testing for our community why is it so important for our community to understand testing, both for patients and for family members?
I think, again, really important points here that there are options for treatment based on information in the bloodline and based on information in the tumor for a subset of individuals. We wish that subset were larger, but for the given person, that's a very real option for their treatment. And as we always tell people, if we don't look, we won't find, right? And even for these rare findings, they're so important. And for the family, I think, again, this is critical information for a family to be aware of. Now, it's nuanced, and not every individual in a family will choose to pursue testing. They may be aware of the risk, but may choose to undergo surveillance and screening, but not individually get tested. Others feel differently. But I think the way we might think about it is knowledge is power, and opportunity for prevention, and opportunity for helping a family that may be at risk of a number of different cancers, and some of which, as we know, can be particularly challenging.
Yep. Yeah. Thank you, Dr. O'Reilly. And, we can certainly remember a time not that long ago where we didn't have this information and weren't able to provide these types of options to patients and their families. So it's certainly exciting improvements in the research. And so, Dr. Pishvaian, let's talk a little bit about the research. I mean, it is exciting that we know now today to recommend to patients that they should get genetic and biomarker testing. You have been very involved in this type of research that's pushed the field to adopt this testing as standard for pancreatic cancer patients. Can you share a little bit about some of the research that you've worked on that's really taught us about precision medicine as we're talking about today?
Yeah, thank you, Julie, and thank you for the question and for the opportunity to be part of this. I'm really excited to be able to bring this up because it's certainly not just our work, but there's been many groups and well over 5,000 patients that have been tested over the last 4, 5, 6 years. And they've really taught us a consistent theme, which, as Dr. O'Reilly mentioned, the theme is, if you don't look for it, you won't find it. And we're finding that, first of all, that these actionable mutations that were previously discussed are identified in pancreatic cancer. I think many people used to think that it was very rare in pancreatic cancer, but in truth, up to about a quarter or 1 in 4 patients with pancreatic cancer, their tumors harbor one of these actionable genetic alterations. In addition, though, we're now starting to find a number of therapies that are targeting these actionable alterations. And what we're seeing consistently is that when patients with pancreatic cancer, or really, quite frankly, with any cancer that has a given genetic alteration or mutation or fusion, and they receive the appropriately targeted therapy, that these patients actually benefit, what I like to say, disproportionately. We know the outcome of patients with pancreatic cancer in general, but when we have patients that get tested and are found to have these specific genetic alterations and get access to the quote unquote right drug, they actually do have significantly improved outcomes and survivals compared to what we would normally be used to. And we were actually able to look at this more formally in the context of a clinical trial in a project known as the Know Your Tumor Project, sponsored by the Pancreatic Cancer Action Network, where we tested and followed well over 1,000 pancreatic cancer patients. And many of them, we were able to follow them as they got access to targeted therapies or appropriately matched therapy. So we were able to track these patients, and there was a group of patients that had actionable alterations and were able to get access to the so-called right drug or the matched drug. And then there was a parallel group of patients who also had actionable alterations, but were not able to get access to the matched drug. And when we looked at the outcomes, the survival of these two groups of patients in comparison, we found that patients who got tested and got access to the right drug lived 1 full year longer than patients who got tested. And even if they had an actual alteration, if they didn't get the right drug, then they lived 1 year less than the patients who got the matched therapy. So it really was able to emphasize the need to test and the need to get access to these novel therapies.
Yeah, that was really exciting research that was done, and certainly, that time is so important to patients and families. So, Dr. O'Reilly, as an oncologist treating pancreatic cancer patients, how has your role as a clinician really changed over the last 5 years due to the advances in testing and precision medicine?
Great question, Julie, and thank you. And I just want to echo what Dr. Pishvaian just discussed. It's so important that for these groups of people, we can see a huge relative impact in terms of outcome. And I'll just add to the point that Dr. Pishvaian mentioned. So for example, in the BRCA setting, one of our most targeted medications is actually a relatively old medication. It's platinum chemotherapy. And this has been shown to have a significant outcome. And we see now routinely through multiple data sets that individuals with BRCA and pancreas cancer, their longevity is probably about double because of the treatment impact, not because of the underlying presence of the gene, but because of the treatment impact. So really, really important to test. And with that, to directly answer your question, it means we need to test. And it takes work, it takes time, it takes education, it takes blood testing, it takes insurance reimbursement, and it takes tracking down tissue. And if I can bring up the issue of tissue in pancreas cancer, it's a relative luxury, and traditionally tissue testing has been small needle biopsies. That's changing, and this is a message we want to share with the community that where possible and where safe, we want to get cores, even microcores or something called a cell block. So Dr. Klein and her colleagues can help us really analyze these tissues at a deep level. And it is particularly challenging in pancreas cancer because there's a lot of other components other than just the cancer cells. There's this stroma, this supporting matrix, and that can be difficult to get through. We can see just relatively few malignant cells, and even those that are there, they can be challenging to actually sequence in terms of genetics. But it's important, if the first attempt hasn't been successful, that for many individuals, it'll be worth going to the second. And if I can also just mention the emerging role of liquid biopsies, and I think they are going to have a really important place in pancreas cancer. And I know as part of our panel this evening or today, we're going to have more discussion on that topic too.
Yeah, no, thank you for bringing up the tissue issue, and that we're continuing to learn, and this is an area where we're so grateful to supporters who are funding this amazing research, and of course to the patients who are willing to participate in clinical trials so that we can continue to learn. So, Dr. Pishvaian, from a research perspective, what do you think is next up on the horizon related to testing and precision medicine for pancreatic cancer patients?
Great question, Julie. And I think that there's three ways that I would tackle this question. The first most important is really just getting the message out. And I think groups like the Pancreatic Cancer Action Network and others have really been stellar in pushing the need to test. As Dr. O'Reilly just mentioned, we just have to get these community practices and academic centers too to be testing routinely. As far as what's next in precision medicine and testing, I think that one area is growing the breadth of testing. So looking into other ways of identifying genes and the consequences of genes, the RNAs and the proteins, to see which ones are relevant to a given cancer cell. So RNA sequencing, even protein testing may really start to play a bigger role than it currently is. We hope that the roughly 25% of patients that we see that have an actionable alteration, maybe that number will grow to 30, 40, 50% if we identify other ways of testing for these actionable alterations. And then the last part I would mention is the depth of understanding of what we're actually testing. I think some of the work that Dr. Klein is doing, I'll give her a nod, is really exceptional in this way, because we're not just starting to look at yes, no, is there a mutation in a certain gene, but what is actually the functional relevance of a certain mutation in a gene. The group that ran the POLO trial, including Dr. O'Reilly and Dr. Golan, took a deep look into the BRCA mutations, the specific kind of BRCA mutations that were identified in patients who enrolled in the POLO trial. And the goal being to try and see, is it the presence of a BRCA mutation in general, or are there specific mutations within the BRCA1 and BRCA2 genes that are going to drive the responsiveness to platinum-based therapies or to PARP inhibitors or to other therapies out there? Or equally importantly, on the other side of the coin, are there specific mutations that are going to drive resistance to these therapies, so that we shouldn't reflexively give patients with those kinds of mutations therapies that we think target those specific mutations?
Yep, great. Yeah, it's exciting to think about what's ahead. So Dr. O'Reilly, how about you? What are you excited about in this area over the next 5 years?
I'll tell you what I'm really excited about in pancreas cancer is that there's just increasing awareness of this disease. There's increasing focus on this disease. We see more and more younger colleagues wanting to work in pancreas cancer, right? And seeing that there's momentum and there's enthusiasm, comes with that research dollars, comes with that brain power, right? And I think optimism that meaningful steps are going to be made. So that's kind of a bigger picture thought. In terms of specifics, I'm ever the optimist and hopeful that immunotherapy is going to have a major role in this disease. I really think we've got some hints now of subsets of patients that have immune responsive tumors that can be manipulated. We have some suggestion of who they might be. We need to leverage that better. I think better understanding of how the stroma and the tumor interact and how we can effectively target that, and building on the points that Dr. Pishvaian mentioned, is just even expanding the targeted options that are on the table today to all of the people who are affected with this disease. That in of itself is going to move the bar, right? Just people having access to the current state-of-the-art approaches and state-of-the-art therapies. Change is afoot in this disease.
Yes, I think you're right, and it really is exciting. And to your initial point, boy, the field is growing, and there are more researchers focused on the disease, and smart people like all of you who are tackling this difficult challenge. And it does feel now like we learn something new much more frequently, and than we certainly used to. There's new information that we're having to explain to patients, and it really is exciting. So, Dr. Klein, let's shift gears here a little bit and talk about an individual's risk for developing pancreatic cancer. Dr. O'Reilly has touched on it a little bit, but as she shared, the research advances in testing are also significant for family members of pancreatic cancer patients. So as an epidemiologist and a geneticist, can you speak first to the latest guidelines for family members of pancreatic cancer patients?
Sure. So around this time in 2019, as Dr. O'Reilly nicely laid out, the recommendations were that pancreatic cancer patients undergo germline genetic testing, often using kind of a hereditary cancer panel. So the blood-based testing Dr. O'Reilly talked about. Now those recommendations also extend to first-degree relatives of patients, particularly in instances where that pancreatic cancer patient didn't undergo testing or wasn't available to be tested. So we don't have that information on them. If the pancreatic cancer patient themselves was tested and were found to have a mutation, then it's very important that those family members also kind of consider whether or not genetic testing is right with them in conjunction with their healthcare providers or a genetic counselor. If the family member was tested and were found to not have a mutation, that's the one instance where often testing isn't recommended for their relatives.
Great. So there are a lot of new blood tests. A couple of them have come up already in the conversation that are available now or being studied that can potentially detect pancreatic cancer before it causes symptoms, or at least earlier than we are able to do now. Can you explain some of these new tests and how do they fit into this overall picture of early detection?
Sure, absolutely. So the blood tests, the genetic blood tests that Dr. O'Reilly was talking about, that I were talking about, are kind of germline. They measure the DNA that you were born with and look for kind of inherited changes. And those have really, they've been around for a while, but our ability to do them has kind of increased. They've become a lot more inexpensive. Those are the type of tests companies that offer them, such as Invitae or Color Genomics. And these are what are recommended based on kind of NCCN guidelines. In addition, Dr. O'Reilly talked about kind of somatic changes. So these are changes specific to the tumor. Sometimes they can be DNA changes, but there's also other types of changes, such as methylation, such as blood markers. Now we're learning how to test for those. So changes in the tumor that might then be shed into the blood that we can then test for. And this might be an opportunity to kind of develop a new line of early detection tests. So we've seen in the past, 5 years, a lot of development of this test in different aspects, measuring kind of different things, but all showing great promise for the earlier detection of cancer. Some of these are available in limited settings. However, none are yet approved by the FDA, but they're tremendous promise both in the high risk setting and in the average risk setting. Can we identify these early changes in blood that might offer us a new opportunity for earlier detection? So it's very exciting and promising, but not routinely kind of guidelines as we were talking about with the germline genetic testing.
Right. Yeah. Certainly a step in the direction that we all want and desire, which is an early detection test for the disease, but we're not quite there. But it is exciting. We're making steps towards it.
And I'm really looking forward. I think there'll be a lot of exciting kind of clinical trials in this space in the next couple of years, where we'll really learn a lot and learn how to move this field forward.
So what is some of the exciting research that's going on now related to early detection?
Well, we've seen a lot of these tests I mentioned, I think are incredibly exciting. We're also, with kind of technology, we're learning how to better interpret our CAT scan images, maybe MRI images, using kind of advanced machine learning, artificial intelligence techniques. Maybe we can train using computers to pick up things that the eye can't see. And maybe we can merge these tests kind of together and to kind of bring them forward and apply them, I think, first in these high risk settings, whether it's the mutation carriers that we talked about where we know the genetic cause. We also know that we don't know all the underlying genetic causes. So if someone has a very strong family history, they might still be at risk even if we don't find they have these mutations. And hopefully we can learn how to apply these exciting earlier detection techniques in there. And the combination of kind of traditional imaging, endoscopic ultrasound, MRI, and high risk settings with some of these molecular tests as well, I think are incredibly promising.
Yeah, really exciting. So I'm so thrilled that we have a 5-year survivor, Teona, on our panel. It's always great to take all of this exciting and important research and really, at the end of the day, it is for the patient. So Teona, let's just start. Tell us how you were diagnosed with pancreatic cancer.
Sure. And thank you, Julie, so much for having me here. And I just have to say thank you to all the doctors that are on the panel. The work that you do is so incredibly important. And as a 5-year survivor this year, I'm really grateful for all of the changes and everything that's coming. This is exciting news. But as far as how I was diagnosed, it was in 2016, and I had very subtle symptoms, but they were symptoms that I'd had for quite some time. I had the lower back pain, I had abdominal pain, I was fatigued, all of those things that we hear about so often, but I was 41 years old and I'd never really even heard of pancreatic cancer before. So the symptoms didn't even resonate with me to think that something was wrong. And initially I was misdiagnosed with an ulcer. A few other things, it was kind of like the H. pylori virus, and then maybe it's an ulcer. And no one was actually checking for pancreatic cancer, in part because of my age. So when I went and had a CT scan on April 1st of 2016, April Fool's Day, I think everybody, including the doctor that ordered the test, was really surprised to see that I had a 7 some odd centimeter tumor that was covering the tail of my pancreas. Incredibly unexpected. I went to a specialist right away, and even still, he said it's probably just a cyst, mostly water-based, not a solid tumor. Wait a couple of weeks, come back, and then we'll take a look at it again. But my mother said, no, you need to go and have this checked out. Thank God for mom. And I very reluctantly went and had some follow-up tests done. And because of PanCAN Patient Services, I was actually able to get connected with the Winship Cancer Center here in Atlanta, Georgia, to get an oncologist that was able to look at my scans and eventually diagnose me with pancreatic cancer, stage 3 adenocarcinoma. The tumor was inoperable at that time. So lots going on at that point.
Yes, yes. What a story. And so similar to so many other patients that we hear about the struggle to actually get a diagnosis of pancreatic cancer. So, Teona, you've had both genetic testing and biomarker testing. What's your hope for how you're going to use that information in your treatment journey?
Sure, that's a great question, Julie, because I was listening to the dates early on that we were talking about when all of the testing became just kind of the standard, and that was several years before. So I actually, again, went through patient services and Know Your Tumor. The program Know Your Tumor was how I decided to get genetic testing, and it was a little bit trickier because at that point I'd already gone through treatment. They had already removed the tumor successfully, and the course of treatment I had was chemo first, so they'd shrunk the tumor. So there was very little sample tissue left, but there was just enough to do the testing, and that ended up being really critical. And then on top of that, I did genetic testing as well. So even though I didn't have a family history, it was interesting because the BRCA1 mutation did show up in the tumor. I just didn't have a positive germline test for it. So I think the way we'll use it going forward is just really thinking about how my kids might be impacted. The germline testing was a bit inconclusive because we didn't have a lot of family history. But not only that, I was able to get a really nice list of other cancers that I could potentially be impacted by. What treatments would be the most feasible and the most accessible. We talked about that earlier on in this webinar. Having the right treatment is really what leads to the best patient outcomes. So for me, that's how I'm going to use the testing going forward.
That's great. And, Teona, one of the important messages we want to get across, we know that African Americans have a higher incidence of pancreatic cancer than other racial groups. So what message do you want to get out to the African American community?
Yeah, thank you, Julie, for bringing that up because, again, going back to my diagnosis, I didn't have anything that would have suggested that I would have pancreatic cancer except for the fact that I'm African American. So I would really encourage the people in the Black community to know the symptoms. One of the huge symptoms is really inexplicable weight loss. If you're losing weight for no reason, that is a sign that you need to go to the doctor. You should never not be just losing weight for no reason at all. And really look at getting genetic testing, get the information, find out either through patient services or just even through pancan.org what the symptoms are, how treatments are going to impact you, even testing for your family. I think it's just a matter of what we've already said, knowledge is power, and people have to have the knowledge to even be able to begin to pursue the correct treatment options.
Absolutely. And it's such an important message to get the word out about, understanding what the symptoms and the risk factors are for pancreatic cancer so we can be our best patient advocates. And we certainly want the African American community to understand that they also need to pay attention to these symptoms and risk factors. So thank you for being such a wonderful ambassador. What would you say to someone that may fear getting tested?
So that's a great question, Julie, because my kids are now 20, almost 21 and 18, so they're young. We've started to talk about testing in my home with my children. And of course, they're thinking, we're young. Who wants to think about testing? We have our whole lives ahead of us. And sometimes there's a fear of, I don't want to know. What I would tell people is, yes, you do want to know. The outcomes are better. We don't have early detection right now. This is the closest we can get to early detection methods that we know will save lives. Not just save lives, but prolong life. And I would tell people, even if you're afraid, get the information because it can tremendously impact your outcome for the better.
Yeah, absolutely. And as I think several people have now said, knowledge is power, and it really allows you to be in the driver's seat of your own health. So this has been a great discussion. There's so much terrific information. We're getting a lot of questions in from our viewers, so I want to turn to some of the questions that are coming in. So Dr. O'Reilly, how is pancreatic cancer most commonly diagnosed today, and what is the best diagnostic test?
So thank you, Julie, for that question. And if I could just take a moment to compliment Teona, that was so eloquent and such an important message for the audience to hear. Thank you for sharing your story and being so direct. And if I can also say just two other things that Teona's story brought up, is that we are seeing a change in whom is diagnosed with pancreas cancer. And this is an important message for us all, that there is a little bit of an increase in younger people, still mostly a disease of older people, but in particular in women. And that's not fully explained. And Dr. Klein, in her epidemiology role, may comment on this in a few minutes. But I think for the audience, these are important points to be aware of and to be persistent with one's symptoms for investigation. So going back to your question in terms of how is pancreas cancer diagnosed, so typically the common symptoms would be the ones that Teona mentioned, including in addition, developing jaundice, dark urine, itching, insidious back pain, weight loss, blood sugar going up, new onset diabetes, and that's a very important area in the screening space as well now for select people. But those symptoms should prompt imaging, and an optimal scan is a CT pancreas angiogram, which is a special scan. You get intravenous contrast, you get fine cuts through the pancreas, and you can see if there's a tumor there. You can see if there is, what the blood vessel relationship is. You can see if there's evidence of spread of the cells to other parts of the body. An ultrasound can be used, but it doesn't have the sensitivity and can miss a lot. So, and it's very dependent on the user. So a CT or an MR would be the initial screening tests. And if an abnormality is identified in the pancreas, often an endoscopic ultrasound, so like an upper endoscopy with a camera, opportunity to visualize directly an abnormality and to biopsy that abnormality. Sometimes we'll biopsy lymph nodes, liver, lung lesions if there are cells in other parts of the body. So they would be common ways to diagnose this disease, sometimes with supporting information from blood tests. CA99, it's a blood test that can be elevated, or CEA is another, perhaps less commonly elevated blood test.
Great, thank you. Dr. Klein, do you want to build on, where Dr. O'Reilly started, and maybe building on even the conversation with Teona about the African American population having a higher risk of the disease, and then what we're seeing in some of the diagnosis today?
Sure, absolutely. I mean, we have seen not only are the absolute numbers of pancreatic cancer increasing each year, and part of that's the aging population, but as Dr. O'Reilly mentioned, there is, with each age that we see a greater risk of pancreatic cancer than there were 10 or 15 years ago. We don't fully understand why that is. Part of that might be kind of the increasing rates of obesity in the population. And we know obesity is a risk factor for pancreatic cancer, but we touched a little bit on diabetes. So diabetes, kind of longer standing diabetes, has historically been shown to increase your risk of pancreatic cancer, 50%, maybe up to a twofold increased risk. But more and more we understand that individuals who have a recent diagnosis of diabetes, particularly uncontrollable diabetes, that's not easily controlled with diet, might have underlying pancreatic cancer or high-grade precursors. And that's really an area where we're focusing in and doing targeted kind of early detection screening, in part through PanCAN's early detection initiative. And that might be offer a wonderful opportunity to kind of detect this disease earlier. And that might explain why we see more young diabetes, obesity, why we see more younger people and more pancreatic cancer kind of in the population in general. African Americans we've always known they've been at a slightly increased risk of pancreatic cancer, maybe 40%. We're really trying to understand the reasons behind that. We don't know. And part of that, our research is challenged because of historical reasons why African Americans are less likely to participate in research studies. But we're making inroads into that area. We have a large genetic study to really focus on, the genetics of pancreatic cancer, inherited genetics in African Americans, because African Americans are woefully underrepresented in genetic studies. So a lot of our knowledge comes from studies of European populations, but we really need to understand, what are the differences, why there are differences, to really kind of tailor these precision medicine as we move in that front to make sure we're giving the right treatment to the right patient at the right time.
Yep, great. It's really important. So, Dr. O'Reilly, someone's been diagnosed, and I'm sure you all get this question. What's the best way to check for a reoccurrence? Patients are very concerned about reoccurrences.
Yes, thank you, Julie. Very, very important question for sure. So several things, how a person's looking and feeling is very informative. And as we always tell people, they know their body. So a change or a difference, and again, just going back to what Teona mentioned, right, is a spark that something was amiss. So that's key. Blood tests, these tumor markers, CEA and CA19-9. I will just say, though, there are caveats with those, and we try not to make decisions on blood tests in isolation. It's the totality of the information. Imaging is very important as well, both for evaluating people who are actively on treatment, to looking to see if their cancer is responding and if that particular program of treatment should continue. And also just after a person has undergone surgery and their cancer has been treated, in terms of surveillance, again, looking for recurrence. And we are seeing some emerging biomarkers or blood tests in this area. So just going back to genetic information, there may be shed tumor cells or shed DNA from tumor cells in blood. That's called ctDNA, that can be circulating. And this is something that's not right now actionable in terms of day-to-day use, but this is undoubtedly going to have a major impact in terms of how we practice, both in terms of selecting treatments for given people, for detecting recurrence, and for perhaps targeting early recurrence when there's a much lower volume of cancer cells present, that the impact in terms of treatment at that point may be better. Now, there's a lot of ifs there right now, but I think that's clearly a direction that the field is going.
Yep, another great example of the progress that we're making because of research, and certainly the need for us to continue to invest in pancreatic cancer research. So Dr. Pishvaian, there's a question that's come in from a viewer about clinical trials. This person was just diagnosed with pancreatic cancer. They're contemplating if a clinical trial is right for them. What do you think, Dr. Pishvaian, are the most important factors that the patient should consider?
Julie, I think that every patient should consider a clinical trial very seriously. And I think not just for the patient individually, but for the greater good. We know that 3% of patients with pancreatic cancer enter into clinical trials. And while we really have made progress in many ways in the last 10 or 15 years, you can just imagine if that 3% were 80%, how much more rapid the progress could potentially be. What I discuss with patients about clinical trials, and obviously I do come from a slightly biased perspective, being a clinical trialist, but at the same time, I'm really trying to help the patient understand that we have limitations in what we're able to do, especially for patients with more advanced pancreatic cancer. And so the goal of a clinical trial is to learn, but also to be able to push the envelope on how their treatment is going to be and how their outcomes are going to be. We have gotten better in some of our treatments, so I would never recommend that a patient necessarily skip out on what is a standard therapy that has some proven benefit in place of just something completely off the mark. But a lot of the trials are designed specifically that way. They take standard therapy, proven therapy, and they build upon that. And the other part of that is that there's a lot of discussion and fear about receiving a placebo in the trial. But it's actually unethical for us to give a placebo to patients who have options. Now, we'll talk about later line patients in a second, but for patients who are newly diagnosed, they definitely have treatment options, and we have to be able to offer them at least the standard as part of the trial, and then the standard plus perhaps some additional therapy as the experimental arm of the trial. So I would definitely encourage patients. Now, there are limitations to how patients can enroll in trial, and personal decisions have to be factored in. Some of these trials are only located in certain areas within the country. Actually, Pancreatic Cancer Action Network does a great job helping patients find clinical trials that are appropriate for their disease and where they are in their cancer journey, hopefully relatively close to where they live. There are also a lot of trials where the sponsor of the trials will support travel or other ways to try and get access to the therapy and to the trial. And so that's something that the patient and the family and the doctor need to take into consideration as well. And then one final note that I'll make, just bringing back the original topic when we started this discussion, was clinical trials and biomarker testing, because more and more trials are really being designed around these very small niches of biomarker specific patient population. And I think actually to the good, because sometimes what we're seeing more and more is that when you identify a certain patient and you put them on a clinical trial based on their biomarker, many, if not in some cases, most of the patients on the trial are actually benefiting from the new drug. So having the testing done will open up the door to what trial options are out there for the patient.
Yep, no, terrific. So this question from a viewer, they want you, Dr. Pishvaian, to get out your crystal ball. What clinical trials are happening that may lead to the next big breakthrough for pancreatic cancer? And what do you see, I guess, as the next big breakthrough?
Well, I have to stay ever optimistic, like Dr. O'Reilly mentioned. I think if you're not ever optimistic, then you're not going to make it as a pancreatic cancer doctor. But really the goal is that we are trying to find ways to do better. And what I see in the clinical trial world is two directions, not necessarily mutually exclusive, but two main directions. One we've talked a lot about, which is really making the most of genetic alterations and biomarkers. And there are new therapies that are linked to specific genetic alterations, perhaps maybe that we didn't realize were previously relevant. There are also combinations of therapies that are trying to make the treatments we have that are biomarker based even better. And then there are definitely what we call trials looking at resistance mechanisms to some of these targeted therapies. So if you have an actionable alteration, you get on the right drug, hopefully it works for you for a while, but then it stops working while your body, your cancer may have developed some sort of resistant mechanism, and there are now therapies being designed to try and overcome those resistance mechanisms. The other big category of trials, again, is what Dr. O'Reilly mentioned, is in immunotherapy. We know that harnessing the body's immune system to fight cancer as a principle works. You know, people, the Nobel Prize was given out for that, basically. Mm-hmm. And so it works in lung cancer, it works in melanoma, it works in certain kind of cancers, and we just haven't quite gotten it to work in pancreatic cancer the way that it has in these other cancers. But there are some very, very brilliant scientists and clinician scientists out there that are really teasing apart what's going on with the body's immune system, what is going on in the pancreas tumor that's preventing the pancreas cancer cells from being chewed up by the immune system. And with newer combination therapy trials, we're starting to make some progress. And I feel like the glass ceiling that we're going to break through to make immunotherapy work is getting closer and closer to us, that we can finally get to a point where we're going to identify just the right combination of immunotherapy drugs in a way that turns on perhaps not just one signal like it is for melanoma, but perhaps turns on two signals and turns off another signal to finally get the immune system to be able to fight the cancer.
That's really exciting, and exciting to think it's not that far maybe away, that we're getting closer and closer to some of these discoveries. So I think we have time for two more questions from our viewers. Dr. Klein, I'm going to go back to you. This is a great question that will help sort of re-summarize some of what we've talked about. So this person is a first-degree relative of a pancreatic cancer patient. What steps should they take in order to better understand their risk?
Sure. I think knowledge of just not only of the pancreatic cancer patient, but their full kind of cancer family history. A lot of the genes we know about that predispose to pancreatic cancer are also predisposed to other cancers, whether it's breast, ovarian, colorectal. So understanding the full family history, if their relative hasn't undergone or wasn't able to undergo genetic testing, talking to their team, to healthcare team, to a genetic counselor, their provider, to understand if genetic testing is right for them, because that can help inform whether or not they have kind of a high risk gene that we know about. There is a limit to our knowledge. So we only understand a fraction of the genes that cause pancreatic cancer. There's a whole lot that we don't know about, but that knowledge is growing every day. So, a genetic test might not be something you do once in your lifetime, but in 5 or 10 years, there's going to be more knowledge that might help inform it. And depending upon their testing results, also the extent of their family history, they could talk to their team about potentially some of these early detection studies that are out there, particularly if they're older, in their 50s, 60s, or 70s, where we start kind of thinking about early detection screening, because that's when the risks and benefits change a little bit.
Great. And Dr. Klein, one more question. This person has pancreatic cancer cysts, and they're already in a surveillance program. Should they also be thinking about one of these new blood tests?
So I think these blood tests are really promising. At this point, they are not kind of available widespread. While there's certain tests that are available in certain states, they're often not available in certain states, and they're not FDA approved at this point. So I think there's tremendous promise. But right now, I really talk to your healthcare team about what's available for you. But I think if they're undergoing regular surveillance for pancreatic cysts, that's the recommendation right now.
Great. And actually, I'm going to do one more question, Teona, for you. There's definitely lots of questions. Patients have lots of questions, and there's fear, and they want to understand things better. They want to know what's the right thing for them. I know you, Teona, used our patient services program. You mentioned that a couple of times when you were speaking. Can you talk about that experience and why you might recommend for patients to call patient services?
Sure, Julie. That's a really awesome question, because there is a lot of fear and just overwhelmingness when you first get diagnosed. I think so many patients just don't even know what to do. And we all head to the internet and we Google things, and we see that really little, that minor survival rate, and then that causes even more anxiety. But I would definitely say calling patient services was probably one of the best things that I did. My patient services representative was kind and compassionate and really gave me the information that I needed to make the best treatment decisions. Should I do a clinical trial? If I was going to do a clinical trial, what was that? What other treatment options are available for me? Was standard of care the best thing in my area? So all of those pieces of information I got through patient services. And then there were other resources that were available too that were really helpful. So I think really just sitting down, thinking about what information do I need the most right now, and definitely just once you get the diagnosis, then getting the resources and getting the information is the best thing that you do. I cannot express that enough. Even through all of the fear and trepidation, just having the information available is going to help you and your family make the best decisions. And I would also tell people, be their own best advocate. Ask a lot of questions. Even if you don't know what to ask, say, I don't know, but ask a lot of questions. And that's going to help improve your opportunity for getting the best treatment as well.
Yep, great. So once again, information and knowledge is power, and being informed allows you to make informed decisions. So thank you. This was an amazing discussion. What a terrific panel. Thank you, Dr. O'Reilly, Dr. Pishvaian, Dr. Klein, and Teona. Really appreciate all of you, and thank you for the amazing research that you all are doing, which is critical to the advances that we talked about today. And Teona, for being just such an amazing advocate and an ambassador. Thank you, everyone. Thank you to our incredible panelists for taking the time to join us today. That was a truly powerful discussion with a lot of important information. To recap, for patients, PanCAN strongly recommends all pancreatic cancer patients get genetic testing for inherited mutations as soon as possible after diagnosis and biomarker testing of their tumor tissue to help determine the best treatment options. For those who may have a brother, sister, mother, father, or child who has had pancreatic cancer, we recommend that you talk to a genetic counselor to help you understand whether you should have genetic testing. And PanCAN's Patient Services can help you prepare for that conversation. For everyone, PanCAN Patient Services has free resources and information for patients and family members to help you understand why testing is important to determine the best treatment options if you are a patient, and to understand your risk if you are a family member of a pancreatic cancer patient. PanCAN's trained case managers are ready to take your calls and emails Monday through Friday from 7 a.m. to 5 p.m. Pacific time. The phone number and email are on the screen. I hope that everyone will continue to spread the word during the rest of this month and beyond. If you haven't heard the news yet, we are so excited that Jen Landon, the daughter of the late actor Michael Landon, Star Trek's Kitty Swink, and PanCAN advocates Nick Pafani and Teona are brand ambassadors for Pancreatic Cancer Awareness Month. They are part of a PSA and digital campaign that has been running throughout this month. Let's watch Jen Landon and Teona's spots.
Hi, I'm Jen Landon. 30 years ago, my father, Michael Landon, passed away from pancreatic cancer just 3 months after his diagnosis. November is Pancreatic Cancer Awareness Month, and this month, PanCAN is talking about the importance of testing for patients and their families. So contact PanCAN Patient Services to learn 3 simple steps that could save your life: talk, test, and take control. You will make a world of difference.
I'm Teona Ducre, and I'm a 5-year pancreatic cancer survivor. When I was 41, I was diagnosed with stage 3 pancreatic cancer. PanCAN Patient Services gave me the resources I needed to make the best decisions about my treatment options, including testing. This November, Pancreatic Cancer Awareness Month, I encourage you to contact PanCAN Patient Services to learn about these 3 simple steps: talk, test, take control. Go to pancan.org now to learn more.
Isn't that amazing? We are thrilled to have this incredible support and the awareness that Jen's voice and all of our ambassadors bring to our cause. Jen has also filmed a PSA to encourage donations to PanCAN on Giving Tuesday coming up on November 30th. You can contribute to Progress for Patients. Please go to pancan.org and make a donation now. I'm so incredibly grateful for your generosity. One last note. Hopefully by now you've heard the news that all 59 PanCAN Purple Stride events across the country will be back in person on one big day. Please join us on Saturday, April 30th, 2022 at the Purple Stride near you. And for those of you who can't attend in person, you can join our Purple Stride USA event and participate from wherever you are. Go to purplestride.org to register for free and start fundraising today. A huge thank you to these local premier sponsors for stepping up to support Purple Stride in their local community. We can't wait to see all of you back together in person at Purple Stride next spring. From all of us at PanCAN, happy Pancreatic Cancer Awareness Month. Be sure to follow PanCAN on our social media and help us continue to spread the word about the importance of testing. Thank you for joining us today. I hope everyone has a safe and happy Thanksgiving.